A 59-year-old male presents to the clinic reporting severe, ongoing pain in his right hand, with persistent numbness and tingling that wakes him at night. Carpal tunnel syndrome is the most common upper extremity compressive neuropathy, affecting roughly 4% of the general population. The standard protocol for typical carpal tunnel syndrome follows a clear, conservative progression. Treatment begins with nighttime wrist bracing and nonsteroidal anti-inflammatory drugs. If symptoms progress, corticosteroid injections are introduced. When all conservative measures fail, the final step is a surgical release of the flexor retinaculum to relieve pressure on the median nerve. For this specific patient, the clinical picture appears perfectly straightforward. He is a truck assembly worker who builds tractor-trailers and operates a welding machine for extended periods. His daily activities place immense, repetitive stress on his wrists, mimicking standard mechanical etiology. He undergoes a successful open carpal tunnel release on his right hand, but 2 weeks postoperatively, he returns to the clinic. He has developed the exact same severe symptoms in his left hand. Clinical data shows that bilateral presentation occurs in up to 60% of carpal tunnel cases. In many patients, this can be attributed to fluid retention, autoimmune inflammation, or anatomical variations. However, in specific older demographics, bilateral symptoms frequently point to a different pathology altogether. Dismissing bilateral carpal tunnel syndrome in older patients as a mere consequence of a lifetime of manual labor creates a dangerous diagnostic blind spot. Treating the wrists as isolated, degraded joints masks a much larger systemic pathology operating beneath the surface. The hidden pathology driving the bilateral nerve compression in this demographic is systemic amyloidosis. Amyloidosis is a protein folding disorder. It is characterized by the extracellular deposition of insoluble fibrillar proteins. Instead of being broken down and cleared by the body, these misfolded proteins circulate, structurally alter, and aggregate into rigid chains. These circulating misfolded proteins exhibit a specific affinity for the connective tissues of the wrist. They migrate from the bloodstream and selectively accumulate within the flexor tenosynovium. Over time, the localized edema and continuous deposition create a rigid, space-occupying lesion that chokes the median nerve. True occupational overuse causes the ligament itself to thicken through mechanical wear and tear. In amyloidosis, an external, systemically produced protein physically invades the carpal tunnel and displaces the local anatomy. To understand the prevalence, a study by Donnelly et al. At the Cleveland Clinic examined patients undergoing routine surgery for idiopathic carpal tunnel syndrome. During the releases, surgeons took biopsies of the flexor tenosynovium. The findings showed that 10.2% of men older than 50 and women older than 60 tested positive for amyloid deposition. Reviewing the dataset reveals one vital correlation. Exactly 100% of the patients who tested positive for amyloidosis presented with bilateral carpal tunnel symptoms. In men over 50 and women over 60, bilateral carpal tunnel syndrome highly correlates with the earliest physiological warning sign of a lethal protein disorder. Returning to our 59-year-old worker, his demographic profile and bilateral symptoms elevated the surgeon's clinical suspicion. During the initial release, the surgeon made the real-time decision to perform a tenosynovial biopsy. This image displays the actual intraoperative finding. Next to the open surgical site is the small, excised strip of tenosynovium required to test for amyloid deposition. Upon opening the wrist, the surgeon encountered a large area of synovitis surrounding the flexor tendons. This gross visual abnormality reinforced the necessity of capturing a tissue sample for pathology. This H&E stained tissue slide shows the microscopic pathology of that biopsy, verifying the disease at the cellular level. The primary visual markers are deposits of pale pink glassy hyaline material, marked by black arrows, displaying a characteristic cracking artifact. The pathology report also notes the presence of foreign body giant cells surrounding these deposits. The immune system is actively attempting to clear a foreign substance, definitively ruling out localized mechanical wear. Extracting a pathological specimen during carpal tunnel surgery is the definitive method to transform a routine mechanical release into a life-saving systemic diagnosis. This presents a logistical challenge. Orthopedic surgeons cannot feasibly or safely biopsy the tenosynovium of every patient presenting with hand numbness. This flowchart outlines a two-tier screening algorithm to standardize clinical suspicion. The first tier establishes demographic baselines: male age 50 or older, or female age 60 or older. The symptom requirement is the presence of bilateral carpal tunnel symptoms, or a prior release surgery. The primary diagnostic rule of the algorithm is simple. If a patient meets any two characteristics from the Tier 1 box, the surgeon must perform an immediate tissue biopsy during the release. Applying this rule to the 59-year-old truck assembler, his profile mandates a biopsy immediately. He is male, over 50, and upon returning to the clinic, presented with bilateral symptoms. If a patient meets only one characteristic from Tier 1, the algorithm directs the clinician to Tier 2. Tier 2 contains secondary systemic and orthopedic history markers. Having one Tier 1 trait and one Tier 2 trait triggers a biopsy. These include spinal stenosis, a biceps tendon rupture, previous atrial fibrillation, the presence of a pacemaker, congestive heart failure, or a family history of ATTR. Strict adherence to this two-tier algorithm eliminates unnecessary laboratory testing and limits surgical time, while ensuring that the highest-risk patients are correctly identified before they leave the orthopedic clinic. Once a synovial biopsy yields a positive baseline result for amyloid, the laboratory work must escalate immediately. The lab must apply specialized staining techniques, specifically Congo red or thioflavin S, which allow the amyloid deposits to be properly visualized and confirmed under polarized light. As shown in the bottom left of the diagnostic flowchart, the next mandatory step is amyloid typing using mass spectrometry to identify the exact nature of the protein. Typing is not optional. The clinician must distinguish whether the disease is light chain, or AL amyloidosis, driven by clonal plasma cells, or ATTR amyloidosis, involving transthyretin proteins. These two variants require entirely divergent treatment paths, ranging from aggressive chemotherapy to targeted immunotherapy. Newly approved therapies exist for both AL and ATTR variants, and they dramatically improve survival rates. However, their efficacy is strictly dependent on administration during the early stages of the disease. Left untreated, misfolded proteins continue circulating in the bloodstream. They migrate from the wrist and systematically infiltrate major organ systems, gradually compromising structural function. Identifying the specific amyloid protein type is the exact diagnostic mechanism that connects an isolated orthotic discovery to systemic patient survival. With a confirmed diagnosis, the clinical focus shifts entirely away from the structural degradation of the wrist. The immediate concern becomes evaluating the primary cause of mortality in amyloidosis: cardiac infiltration. As the rigid proteins deposit into the heart muscle, they cause severe ventricular thickening. This ultimately leads to heart failure with preserved ejection fraction and restrictive cardiomyopathy, the fatal end-stage manifestations of the disease. The onset of bilateral carpal tunnel symptoms routinely predates these overt cardiac manifestations by up to a full decade. Once a patient becomes symptomatic for cardiac involvement, the physical architecture of the heart has already been severely compromised, and the prognosis drops precipitously. Currently, there is a gap in established medical guidelines regarding how to monitor patients who test positive on a rest biopsy but display zero systemic symptoms. The recommended protocol for these asymptomatic patients is a comprehensive baseline screening panel. This must include targeted laboratory tests, an electrocardiogram, and an echocardiogram to evaluate for any subclinical organ involvement. Managing this requires an immediate multidisciplinary handoff. The orthopedic surgeon must actively integrate hematology, oncology, and cardiology into the patient's care plan to stratify the risk and prepare the targeted therapies. Even if the baseline cardiac tests are clear, primary care providers are advised to maintain a low threshold for aggressive evaluation if any new systemic symptoms arise over the following decade. By recognizing bilateral carpal tunnel syndrome as a systemic red flag, orthopedic surgeons gain a critical 10-year window to intercept a fatal disease long before it strikes the heart.